Cardiac reflexes are fast-acting reflex loops acting between the heart and the central nervous system that contribute to regulation of the cardiac function and maintenance of physiological homeostasis. They are fast-acting, centrally mediated negative feedback mechanisms which maintain homeostatic control of the cardiovascular variables. So they sense the changes in the heart rate, blood pressure, and arterial oxygenations through the peripheral receptors and respond by altering the myocardial function and the peripheral vascular resistance. Stretch receptors in general, uh, the humans, they usually maintain their own blood pressure by means of these mechanosensitive receptors, which are present on the afferent autonomic nerve terminals in the adventitia of the large blood vessels and cardiac chamber. They get activated when they are stretched because the walls of the vessel is being distended. The first cardiac reflex which we are going to see is the baroreceptor reflex. Baroreceptor reflex is the priority of over all the other reflexes. The stimulus for the baroreceptor reflex is a pressure, that is a stretch. And the sensor is a stretch sensitive mechanoreceptors in the carotid sinus and the aortic arch. The afferent nerves are vagus nerve, that is the 10th nerve which carries afferent fibers from the aortic arch, and the 9th nerve, that is a glossopharyngeal nerve which carries fibers from the carotid sinus. The processor are the nucleus of the solitary tract and the caudal ventral medulla. The efferent fibers are sympathetic fibers to the heart and the peripheral resistance vessels, and the vagal efferents to the cardiac ganglion, so which mediates the heart rate. So the effector will be present in the myocardium, SA node, atrioventricular node, and vascular smooth muscle. So the effect will be, there will be increase in heart rate and blood pressure in response to fall in blood pressure. So this is about baroreceptor. Moving on to the second reflex, there is a Bainbridge reflex. It is also called as the atrial stretch reflex. It is nothing but increased venous filling of the heart leads to a rise of venous pressure and to acceleration and dilatation of the heart. The atrial pressure rises slightly or maintains steady. So what happens is the quickening of the heart rate is reflex in origin, as it is no longer occurs after the division of the vagal and the cardiac acceleratory nerves. So when you are giving more volume, there will be increase in the heart rate, because increase the rate of the flow into the ventricles and the rate of the flow out of the ventricles will also increase. So, but it does not occurs in all the situations. For example, in the case of hypovolemic shock, the patients are tachycardic, and when we give them more fluid, the tachycardia improves. That is, giving volume is expected to decrease the heart rate. The tachycardia in this case is mediated by the baroreceptor reflex, which seems to completely override the Bainbridge reflex. So the baroreceptor and the Bainbridge reflex are two opposite reflexes which we have to remember. So to demonstrate, the ability to experimentally demonstrate the Bainbridge reflex largely depends on what the baroreceptor activity and heart rate of the subject that has been prior to the fluid bolus. And most important is this Bainbridge reflex is weaker than the baroreceptor reflex, and the baroreceptor will always overrule the Bainbridge reflex in the autonomic forum of the central nervous system. So, and there is one more reflex which is called as a reverse Bainbridge reflex, which means which decreases the heart rate in response to decrease the preload. This is which occurs in spinal anesthesia, where the blood pressure and the cardiac output and the venous return are decreased because of the sympathetic nervous system, when there is a blockade of the sympathetic nervous system. So to conclude, in hypervolemia, the Bainbridge reflex is dominant, and in hypovolemia, the baroreceptor reflex is dominant. So the stimulus for the Bainbridge reflex comes from pressure, again the stretch. Sensors here are stretch sensitive mechanoreceptors in the atria and the pulmonary arteries, that is the type B receptors. Afferent nerves is again the 10th nerve, vagus, which carries afferent fibers. Processor is the same, nucleus tractus solitarius and caudal ventral medulla. Efferent nerves are sympathetic fibers to the heart, and vagal efferents to the cardiac ganglion, which is similar to that of the baroreceptor reflex. Effector is again the same, SA node and the atrioventricular node. Effect is increased right atrial pressure produces an increase in heart rate. But we have to remember is unless the patient is hypovolemic and tachycardia, in that case, baroreceptor reflex will take precedence. And moving on to the third reflex, that is the chemoreceptor reflex. In chemoreceptor reflex, the afferent is said to be cardiac, carotid, and aortic chemoreceptors. That is, the stimulus will be low PaO2 or high PaCO2. And the sensors will be present in the carotid body glomus and aortic body glomus. Afferent nerves are same glossopharyngeal and vagus. Glossopharyngeal nerves which carry afferent fibers from the carotid sinus, and vagus which carry afferent fibers from the aortic glomus. Processor is again nucleus tractus solitarius and nucleus ambiguous. Efferent fibers are sympathetic fibers to the heart and the peripheral smooth muscle, and vagal efferents to the cardiac ganglion. And effector will be again SA node, AV node, peripheral vascular smooth muscle. Here the effector, it is divided into primary and secondary. Primary is vagal effects for because of the 10th nerve, bradycardia, and sympathetic effect will be hypertension. So normally when there is an hypoxia, we can expect hypertension and bradycardia. The secondary effect will be increased preload due to increased ventilation and thus activation of the vein bridge reflex, which increases the heart rate. There will be a reflex tachycardia and activation of the pulmonary stretch receptors and thus activation of the Herring-Breuer reflex, which will again increase heart rate. So primary, there will be bradycardia, and secondary, that is reflex tachycardia, will be seen. So the chemoreceptor mediated tachycardia, which would normally be the effect of sympathetic stimulation, is usually dampened by the vagal effect of the chemoreflex and baroreceptor activation. That is why initially we see only bradycardia, and after some time only there will be a reflex tachycardia. So the why there is not immediately tachycardia is the cardiovascular system does not signal inside a vacuum. That is, when the oxygen is low, the cardiovascular system will not immediately respond. There are also central respiratory control and central respiratory control. So when there is a moderate hypoxia, the respiratory drive is markedly increased, which results in increased lung inflation. So the patient will have larger tidal volume. So this will produce a more negative pleural pressure during inspiration, which will in turn increase the venous rate, produces atrial stretch, and then trigger the brain bridge reflex, produce an increase in heart rate. So all these things will take time. So that is why we immediately do not see tachycardia and we see a bradycardia. And similarly, there will be an activation of the Herring-Breuer reflex, which occurs when the lung is stretched up. So the net rate increasing effect of these secondary reflexes will tend to counteract the vagal influence of the primary chemoreceptor reflex, keeping the heart rate relatively stable. So moving on to the fourth reflex, it is the Cushing reflex. So that is nothing but neurosurgical reflex. It is a triad where hypertension, bradycardia, and irregular respiration is seen in response to increased intracranial pressure. So for Cushing reflex, the afferent will be mechanoreceptors in the rostral medulla. Processor will be rostral ventrolateral medulla, and efferent will be the sympathetic fibers to the heart and the peripheral smooth muscle, and the effect, as I told, will be hypertension and baroreceptor mediated bradycardia. So why there is hypertension and bradycardia is that because in response to the increased intracranial pressure, the body tries to maintain the cerebral perfusion by increasing the mean arterial pressure. So it is nothing but there is an increase in, that is because of the increase in mean arterial pressure, there is an increase that it causes an hypertension. What we have to remember here is they are mechanosensitive intracranial barosensors which are present in the rostroventral and lateral medulla, which causes this heart rate increase in hypertension and bradycardia. So moving on to Besol-Jarich reflex, that is the fifth reflex which I am going to talk. So they have in Besol-Jarich reflexes, this reflex produces bradycardia, vasodilatation, and apnea. So it was discovered by Besold and Hurt, where they injected some toxic plant alkaloid in the bloodstream of the cat. So what happened? What happened was these toxins, they are sensed by the walls of the cardiac chambers in the same way as the pain are sensed through unmyelinated C fibers. So this will cause some cardiodepressant effect, and it will cause vasodilatation and peripheral circulation, and it will slow the heart rate. That is why we will have decreased bradycardia, and it will decrease the BP and decreases the cardiac output. So this reflex afferent as are from vagus nerve. Processor is the same nucleus tractus solitus. Efferent is vagus nerve and sympathetic chain. Effect is hypotension bradycardia in response. Can you hear me, sir?
Yeah, now there was an interruption.
Sir, now, sir?
Yeah, I'm able to hear you now.
Yes, sir. So this, it occurs in the main stimulus for Bessel-Jarris reflex is when there is a cardiac ischemia or a vasovagal syncope or a shock, or when there is a regulation of the arterial blood pressure. So these, the C fibers which are present are mechanosensory and they respond to the stretch stimulus. So in short, what we have to see is when there is a decrease in circulatory volume, there will be decrease in the atrial stretch. And this loss of stretch decreases the firing of the neurons of the C fiber mediated vagal afferent of the Bessel-Jarris reflex. And this removes the inhibitory effect of the reflex on the heart rate and the sympathetic tone. At the same time, activation of the baroreceptor reflex stimulates tachycardia and vasoconstriction. The additive of these two reflexes is, that is the chemoreceptor, that the Bessel-Jarris reflex and the chemoreceptor reflex, there will be greater vasoconstriction and greater increase in the heart rate. So moving on to the next reflex, that is the oculocardiac reflex. This is nothing but also called as Ashner's reflex or the trigeminocardiac or the trigeminovagal reflex. It usually can arise from the stimulation anywhere in the trigeminal nerve territory, and it appears to be a vagal phenomenon, and it is completely abolished by atropine. So the stimulus for this reflex comes from when there is a pressure to the globe of the eye or the traction of the eye muscles, especially the medial rectus. The sensor here will be a mechanosensitive stretch receptors in the facial muscles, especially periorbital muscles and in the globe of the eye. The afferent nerves will be long and short ciliary nerves to the trigeminal nerve via the Gasserian ganglion to the sensory nucleus of the trigeminal nerve. And from there, via the short internuclear fibers to the nucleus tractus solitus. Processor will be nucleus of the solitary tract. Efferent nerves will be vagus nerve via the cardiac ganglion. And the effector will be SA node and AV node. And the effect which we see here is bradycardia and systemic vasoconstriction and cerebral vasodilatation. The globe of the eye and the retroorbital tissues, they have stretch receptors, and stimulating them can produce a vagal stimulant that is so potent that it can even, the heart may stop to the point of death. Moving on to the next reflex is the diving reflex. So diving reflex is also called as the oxygen conserving reflex, which it is nothing but some survival reflex when there is a set of asphyxia. Both the oculocardiac reflex and the diving reflex, upon stimulation of the trigeminal sensory nerve afferents, produce a cardiovascular reaction which conserves the oxygen and delivers it to the brain. At the same time, apnea develops to prevent us from gulping the water, and the cerebral vessels dilate to promoting flow of residual oxygenated blood to the brain. So the stimulus for the diving reflex are stimulus is trigeminal nerve sensory distribution. Again, the pressure of the globe to the eye or the traction of the eye muscles. When there is a pain in the trigeminal nerve distribution, cold temperature, chemical stimulus of the anterior ethmoid nerves. And sensors will be pain, temperature, chemical, and mechanosensitive stretch receptors in the trigeminal nerve distribution. Afferent nerves will be branches of the trigeminal nerve via the Gasserian ganglion to the sensory nucleus of the trigeminal nerve, and from there via to the nucleus tractus solitus. Processor will be nucleus tractus solitus, rostral medulla, and ventral medulla. Efferent nerves will be vagus nerve and the phrenic nerve. Effector is again SA node, AV node, and respiratory muscles. And the effect will be bradycardia. In sympathetic system, cerebral vasodilatation and systemic vasoconstriction. In respiratory, there will be apnea. So then moving on to the vasovagal reflex. The afferent for the vasovagal reflex is emotional distress or hypovolemia. Processor is unknown, and efferent will be vagus nerve and sympathetic chain. Effect will be bradycardia, systemic vasodilatation, and hypotension. So finally, moving on to respiratory sinus arrhythmia. Sinus arrhythmia is the name given to the total normal variation in the heart rate which occurs in response to normal respiration. Specifically, it increases during inspiration. As the lung bellows interact with because during inspiration the lung bellows will interact with the cardiac pump. On spontaneous inspiration, there is a negative intrathoracic pressure which delivers an increased blood flow to the right heart, and by means of Bainbridge reflex, there will be a heart rate increase which tries to compensate. And because of the various homeostatic regulatory influences, the primary reason for this heart rate fluctuation is an interaction between the medullary, respiratory, and the cardiac center. So it is not more of a coordinated reflex, which is because of the interaction between the lungs and the heart. So the afferent will be uh, interneurons between the pre-Bodzinger complex and the nucleus ambiguous. Stimulus will be from the respiratory pacemaker. Sensors we do not know. Processor will be a nucleus ambiguous. Efferent nerve will be vagus nerve via the cardiac ganglion. Effector will be SA node and AV node. And the effect which we see is decrease of the vagal output during inspiration. That is an increase of heart rate during inspiration. That's all, sir.
Excellent. This answer that you have prepared is a very informative answer for class purposes. But for exam purposes, if you have to write the whole thing, you will take a lot of time. So you will find so short of time to attend to all the other questions. So my suggestion would be to rather go whenever you talk about a reflex, you have to talk about the afferent pathway, the center efferent pathway, and what is the effect. So for all the reflexes, you can make a column like that and then say the afferent, center, efferent, and what is the response and what is the implication to anesthesia. If you make it like that, you can finish the answers easily within the available time. At the same time, you have to give the importance. The most important, first and foremost reflex we always start about is with the baroreceptor reflex, which is important for maintaining the blood pressure. Okay, so whenever the blood pressure goes up or comes down, it is the baroreceptor reflex which is able to adjust it and bring it back to the normal. And the Bainbridge reflex, of course, it's one of the OSCEs. There was a question. A patient after spinal anesthesia develops a cardiac arrest. What reflex is involved in that? So, as you mentioned, it is a reverse Bainbridge reflex, which instead of increasing the heart rate caused bradycardia, and along with the hypotension, the baroreceptor reflex tachycardia could not be having time to come, so patient arrested. That is the answer for that. So all those things you have very well described. So I will just show you a format where you can use that for answering your question.